done enough promotion for this session. We even missed some speakers, so probably or hopefully they will come later on. I think you are going to check that later. So let's see. So, okay. So this session is called the Targeted and Drug Delivery in Nanomedicine and Precise Medicine. And Beat Löffler gave it the subtitle, New Technologies are considered to be highly useful for personalized nanomedicine-based therapeutics. The first lecture, sorry. So we start and welcome our first speaker, Dr. Eldad Elnekave. I hope I pronounced your name correctly. He is director of the International Oncology Clinic at the Davidoff Center in Tel Aviv. His title, Precise Endovascular Drug Delivery for Optimal Efficacy and Minimal Toxicity in Oncology.
Thank you. Thank you very much. It's an honor to be here. Thank you for the invitation. So again, my title is Precise Endovascular Drug Delivery for Optimal Efficacy and Minimal Toxicity in Oncology. Now, in this conference, we focus on clinical nanomedicine, targeted delivery, and precision medicine, the building blocks for personalized medicine. And we hear predominantly about systemic targeted therapy, which can be in several forms. It can be nanomolecules, which rely largely on passive targeting through the EPR effect, enhanced permeability and retention, or highly engineered molecules, which are more active in selective molecular targeting. But we're also aware of the potential pitfalls in both of these methods. So with nanomolecules, we can have off-target effects, specifically anatomically non-specific manifestations of EPR, which can be inflammation. A person with rheumatoid arthritis and cancer, we can't really control where the particles go. Another off-target effect is a manifestation in a hepatic phagocytosis of your particles. And then, of course, there's the scenario which we heard about yesterday, where in essence the taxi arrives but the passenger doesn't leave. So you have perfect precision targeting of the vehicle, but inability to offload the drug. And even in the case of very highly selected and engineered molecules such as siRNA, we have some off-target effect from partial complementary effects of the sense or the antisense strands in an unintended anatomical region. And so the question here is, can we improve precision using anatomic targeting, and specifically using the arterial distribution to the target tissue? And the example that I'll give here will be in treating desmoid tumors. Now, in introducing desmoid tumors, I think this title says it all. So this is a recent review, Desmoid Tumors, a comprehensive review of the evolving biology, the unpredictable behavior, and the myriad of management options. So desmoid tumors are rare. They occur in around 4 in every million per year. What they are histologically are monoclonal fibroblasts, which are producing abundant collagen extracellular matrix and proliferating. Now, they're considered benign because they don't metastasize. But for anyone with a desmoid tumor, they're not benign. They're life-altering diseases, and they can absolutely be fatal because of their mass effect and persistent growth into vital structures and viscera. 85% are sporadic, around 15% are associated with an autosomal dominant familial adenomatous polyposis. Now, the constellation of the fact that it can occur at any age and almost any anatomical region, intra-abdominal, intrathoracic, extra-abdominal, limb, head, neck, tongue, and that up to 30% display some degree of spontaneous regression, that constellation makes it very difficult to find a consensus and evidence-based treatment. It's difficult to accumulate enough patients in a center with enough experience. And compounding of this is the inherent intrinsic resistance to systemic therapy that these tumors display. If you look on the right, you can see that there are severe impairments, physical, emotional, and social, which are accompanying this disease. And again, this is a disease which can affect anyone, but more than half are people under the age of 40. So this is a disease which people will need to live with the disease and the treatment of the disease for most of their life. And we need to keep this in mind when we're treating not just the disease, but the patient. And here are some prognostic factors. So having a younger patient, having a tumor that's large, over 7 centimeters, and an extra-abdominal location, specifically location in the limbs are difficult to treat. There are 3 prognostic groups that are described here. We will be focusing actually on treatment of those with the worst prognoses. We'll be looking at some children with extra-abdominal desmoid tumors in trying to apply a novel approach to this disease. Now, it's a disease which is very enticing to resect because essentially it looks like a lump. And the only really effective treatment that had been demonstrated recently, up until recently, has been surgery, although recurrence occurs in up to 80% of the time. So up to 90% of the time in abdominal wall, and between 40 and 60% of the time in extra-abdominal limb tumors. The problem with these is that we have to consider the histology. So we're not resecting cells which are secretory cells. These are cells that they essentially are born to create scar tissue. And they're hyperstimulated at baseline, and they're proliferating at baseline. So when you operate, you create a genetic environment which stimulates them further. And so it's uniformly seen that the recurrence, when it occurs, is more aggressive and more infiltrative and much more difficult to treat. And this is the challenge. And that's the reason why in the consensus in the sarcoma and soft tissue tumor community has been to back away from surgical resection and adopt a wait-and-see strategy with maybe no intervention or mild systemic approaches. Again, the analogy is not to wake a sleeping dragon. So one chemotherapy stands out as being effective in this tumor, and that is doxorubicin. The first case report of effective doxorubicin for desmoids was in 1993, Nancy Kemeny at Memorial Sloan Kettering, with a woman who had a very large, you can see here on the right, a very large abdominal wall desmoid that had been resistant to 2 surgical resections and multiple rounds of various chemotherapies. But she did respond to a relatively high dose of doxorubicin, 450 milligrams per meter squared. Now, she responded for several years, but when the tumor recurred, retreatment with the same drug was not possible because at that level, you have very high risk of cardiotoxicity. So the drug doxorubicin, and I'll just say, has well-known toxicities. Most of the time, they're bone marrow toxicities. Leukopenia, you can get secondary leukemia. There's a lot of mucositis involved, and most life-threatening is cardiotoxicity, which we can see at 450 milligrams more than 30% of the time if you look 10 years out. It's particularly relevant in children, where you're treating a community children who have a whole life ahead of them. And it's the cumulative dose which has the effect. So, the prominence of doxorubicin was again confirmed by the French sarcoma group that looked over 17 years and found that in France, over that 17-year interval, those patients who had been treated with any number of the chemotherapeutic agents described here, there was a significant advantage in terms of response so 54% versus 12% in those who had received doxorubicin. Keep in mind that here you have 30% who had grade 3 or grade 4 toxicities, as is often expected when you get systemic doxorubicin. And again, an article from the Journal of Clinical Oncology showing a complete or partial response in all of 7 patients treated with, again, a substantial dose of doxorubicin, and leading the authors to conclude that this is the modality which should be used as first-line chemotherapy for symptomatic desmoid tumors. Again, keep the end in mind from the beginning, especially in children, but also in adults. So cardiotoxicity after childhood cancer. And with that in mind, we have a group from Boston Children's Hospital that published last year a liposome-based doxorubicin treatment. So we want to reduce the systemic exposure, increase the effect, and they do describe lower levels of toxicity with substantial effect on the tumors. So around 5% reduction in tumor size in those who responded, and that was about half of the patients, and the other half had stable disease. We had a different approach. So this was our first patient about 4 years ago, and as you can see here, this is a 6-year-old with a very large right axillary desmoid tumor. You can notice in the middle image that large mass that's compressing the thorax and almost restricting movement of the right lung. On the far right image, it's a T2-weighted MRI. Those white signals that you see is evidence of proliferation, cellularity of the tumor, and the areas that are black demonstrate the extracellular matrix and the collagen and the fibrous tissue, which you'll never be able to get rid of. Your goal is to reduce that T2 signal, the cellularity of the tumor. What we opted for was a direct delivery of the drug itself. So this is the setup. What you see here on the bottom in white is a 75 micron bead. In red, those red beads are the size of a 10 micron red blood cell. And then there's a tiny dot. I couldn't make it small enough to represent something which would be on the order of 100 nanometers. Now above, that's the color of doxorubicin. Doxorubicin gets its name ruby. Doxorubicin is it's a naturally occurring red substance. And when the beads are combined with the drug, you see the ionic binding of the drug onto the bead, and then the separation, you end up with a clear supernatant, which you can remove, and then you have a loaded drug on a bead, which we can then deliver selectively through the arterial supply to the tumor. And what we see here, I will actually skip this slide and go directly to show you the targeted vessels. So we have the axillary artery, the dorsal thoracic artery, we have the supracromial artery. And what you'll see at every different slide here is there a pointer? We'll take the middle image on the bottom. You'll see everything you see in black is dye, and the reason that dye doesn't extend further into the arm is because there's a balloon which occludes it. What that allows us to do is to inject gently, getting into the small vessels which we cannot access with microcatheters without getting distribution, what we call non-target embolization, into the hand or anything distal in the arm. Everything else we can get into with a small catheter and put particles where we need them, and we know that in this case the passenger will get off the taxi. The drug will get off the bead. It'll take around 2 or 3 days. And this is the result after 4 treatments and 1 year, so no surgery and no other therapy. We can see almost complete resolution of the tumor with the doxorubicin stain, that red color that you can see around the right axillary region, and almost entire elimination of the T2 signal, the cellularity of that tumor. And in the next patient, we have a 17-year-old with a tumor in the gluteal region, so on the right. Again, most of this tumor is white, cellular, and we can target that one from the left groin into the right internal iliac artery, posterior division. There's a superior gluteal artery, which we know is our target. We can see the sacral bone here. This is a sagittal view, and I can identify that vessel, which is in between sacral bone 1 and 2, S1, S2. We can catheterize that, inject under CT just before treatment And we see in white the contrast material filling up the tumor and going nowhere else. Now we know it's safe to deliver here. We deposit the beads, who are about 50 milligrams of doxorubicin, and this is the appearance after 9 months, essentially left with a scar and almost no viable cellularity. A similar approach here, where there is a tumor in the intercostal region, so on the right chest wall. And what you see here is catheter positions in the right 8th and 9th intercostal arteries. What you may notice are coils. There are some metal coils. This is important. So when we do this therapy, so systemic therapy talks about side effects and maybe nanoparticles. We talk about off-target. We talk about non-target embolization. We want particles going where we want them and not anywhere else. And to do that, sometimes we block small arteries so that they stop there. We've done that here, as we used a balloon in the previous case. And so we managed to deposit the drug where it needs to be. And we can see after the first treatment, you already have a reduction in size and a thick rim of fibrotic tissue around the tumor. And by the second treatment, nearly all of the heterogeneous infiltrative white signal on T2 is gone, and you're left with a round and small black scar. Another case, which I'll, in the interest of time, pass on. Our results, this is an article that's just now in press. We show reduction of after one treatment, 54% in terms of size, and then 70, 90, 97%. So we're essentially able to deliver the drug where it needs to be with almost complete responses every time. And the important point here is that if that tumor does recur in 1, 2, 10, 20, 30 years, we still have the option to return to that blood vessel and deposit more without increasing substantially the cumulative dose of the effective therapy. So what's next? Combining selective intraarterial delivery with nanoparticles, other agents, using local anatomic delivery with also molecular, utilizing regional perfusion to alter pH, temperature, whatnot, in order to change the regional environment and allow more effective therapeutic activity, and further localized delivery of existing chemotherapeutics in other tumors. And with that, thank you very much for your time. This is our team at Schneider and Beilinson Hospital.
Okay, thank you very much. Are there any questions?
Please.
Yeah, could you use the microphone?
Save the children and the other that you treated with such good hands and good brain. The thing I want to ask, did you measure, you have any measurement of the concentration of the drug in the plasma?
Excellent question. We are presently pursuing that. Okay. So we do know from studies of similar beads performed in the liver that the plasma concentration relative to the delivered dose is on the order of 2 to 5%. But we have to keep in mind that the drug itself is metabolized in the liver, so we can't make that assumption that it'll be similar outside the liver.
That's right.
We're conducting those studies now.
You know, drug can metabolize only inside cells. Plasma, there is no metabolism, no enzymes, so really, the metabolism of doxorubicin is so well known for many years. And did you also try to look for metabolites? I think you should. That means you get, that really can give you a kind of a sense how much drug was incorporated, was taken up by the cells.
If you stick around, I'm going to get exactly your recommendations for which metabolites.
I'll stick around.
Thank you. Any other questions?
Yep. Any other questions? Seems to be everything was crystal clear.
Thank you.
What you presented. Thank you very much again.